Okay, are we ready?
Yes.
Hi, everyone. Thank you for joining us today for webinar Infection Control for Dental Practice. My name is Carmen Sanders. I'm a member of the Macaw Tribe, and I'm a Public Health Project Coordinator with the National Indian Health Board. Courtney Wheeler is also here. She's a Public Health Program Manager with the National Indian Health Board, and she'll be also available to assist. This webinar is part of our Project Firstline project. In Project Firstline, the National Indian Health Board is one of many partners on collaborating with the CDC on the project. And this webinar is part of our infection prevention and control learning community. And we also have other activities with Project Firstline that we'd like to mention. We are still accepting applications for a steering committee and mentorship program, and we also have a scholarship opportunity for infection prevention and control training. If you'd like to hear more information about that, please reach out to us. We'd be happy to provide more information. A few things before we get started. We'd like to ask everybody to please make sure your microphone is on mute. We do have everybody muted now, but occasionally, things may happen, and we'll want to make sure that we don't have any background noise. And please be aware this webinar is being recorded. The recording and the presentation slides will be available on NIHB's webpage within a few days after the webinar. And we will have time for questions at the end of the session. So please type your questions into the chat box and we'll make sure that we'll get those to the presenters. Today, we are grateful to have Dr. Rickert and Dr. Shelton Miller presenting. And first, I'd like to welcome Dr. Rickert. She will be our first presenter today. Let me see. Dr. Rickert is the first female American. I'm sorry, hold on just a minute. My screen went off. Let me see. I'm gonna have to do some troubleshooting myself. I apologize.
Is there something I can help with?
Yeah, thank you, Courtney. For some reason, my screen, let me see if I'm gonna see if I can move it over to another area. Let's see. Okay, I think that's gonna work here. I'm sorry about that. So, Dr. Rickert is the first female American Indian dentist in the world. Dr. Rickert attended the University of Michigan from 1968 to 1975. In 1975, she established a private dental practice. She also provided dental care for the Children's Aid Society, the Department of Corrections of the state of Michigan, and the Family Healthcare Organization, FQHC. Recently retired, she is the Anishinaabe Dental Outreach Specialist with the Delta Dental of Michigan. Dr. Rickert's book, Exploring Careers in Dentistry, is published by the Rosen Publishing Company. Her published works are many, featured in the Journal of the Michigan Dental Association, Society of American Indian Dentists, Association of American Indian Physicians, American Association of Women Dentists, Dentistry Today periodical, the Arizona Dental Association, and the Prairie Band Potawatomi News. Sorry. She has served as a health advisor for Native News Online. She has most recently included in the Northern Michigan University Press's Voice on the Water. And welcome, Dr. Rickert.
Well, thank you, Courtney, and thank you, Carmen, for that lovely introduction. Okay, sure. And I thank the National Indian Health Board for hosting this webinar, and I thank the Centers for Disease Control for developing Project Firstline. As Carmen stated, today is just a starting conversation for all of us to learn more. IPC standards for the dental clinic setting can be achieved by training and technical assistance for tribal health officials, develop and adapt existing materials to communicate to tribes, and develop a mentorship program between infection control professionals and tribes, develop IPC courses and certification, design and disseminate demonstration videos, perhaps develop a tribal IPC institute where American Indians and Alaska Natives can learn standard IPC. And finally, develop a performance monitoring and evaluation system for continuous improvement. We all want to improve. When talking about IPC standards, here are some concerns. There are many diverse clinics where American Indians and Alaska Natives receive dental care. These include the Indian Health Service dental clinics, tribally owned dental clinics, American Indian and Alaska Native dental clinics that are located in urban centers, and some centers have contracted with a local dental clinic. For example, the Southeastern Michigan Indian Incorporated in the past had a mobile van from the University of Detroit School of Dental Medicine come to their site and provide dental care. Since this pandemic, that van has not been operating. So we have to consider all those places that American Indians are receiving dental care. And also there are various sources for IPC guidelines, and some of these sources differ a little bit. The Centers for Disease Control and Prevention from the United States government has a downloadable free guide for dental clinics, the Occupational Safety and Health Administration, and each state OSHA department has guidelines for dental and medical clinics. The dental schools that we attended have sent us information, and the American Dental Association has the guide, what they call the toolkit to reopen your practice. And I personally found that guidance to be the most clear and easiest to follow. And I will share all these websites with you. They will be on the NIHB website in a day or two. Now, when we are taking care of our patients, there are several population groups that are at risk. There is the patient population, of course. These patients come from all over our areas. They are all ages from age 2 to 112, and they are in all various conditions of health. We have our office staff that we worry about, and these are usually like us, younger and fit, but nevertheless, we are worried about them. There are other persons in the area of the dental clinic, such as we share building space with other professionals, or perhaps if you're in a tribal health clinic, you share space with administration offices or Head Start programs, or just other people that are not dental. Delivery people come to our dental offices, and repair people come to our dental offices. We want them to be safe. All these population groups also have families. So we want to make sure that their families are protected as well. With the pandemic, there have been many staffing changes already. And our next speaker, Dr. Shelton Miller, is going to talk to you in great detail about the day-to-day challenges in managing a dental clinic in this unprecedented time. I've noticed that we need more assistance because of intake, sanitation, record keeping, and monitoring. It is now recommended that all our procedures in the dental office use a chairside assistant as well as the operator for high volume suction. Previously, when I practiced, I did many procedures without a chairside assistant. For example, if I was adjusting the occlusion, or if I was doing a prosthetic adjustment, perhaps I was taking a final impression for prosthesis, I really didn't need an assistant in the room with me to do that. And as we know, our hygienists do almost all their procedures without a chairside assistant. But now they may need one to place a sealant, for example, or if they were going to use ultrasonic scaling. In hospitals and in dental schools, there exist infection prevention departments. We don't have that department in a dental office, so perhaps we would need a specific assistant to monitor this task. Maybe this assistant requires more training and maybe even a certification. Now, in order for all these changes to be effective, we need our staff to agree with us and buy into the changes. And some of these changes are difficult for the staff. And again, our next presenter, Dr. Shelton Miller, will explain how some of these changes are difficult for the staff. For example, wearing all this PPE makes you quite hot. There are physical changes in the dental clinic too. New signage is alerting our patients about COVID-19 protocols. There are more barriers, such as plexiglass shields available, and stickers on the floor reminding people where to stand. This social distancing does require more space for patients and staff. And of course, our dental clinics were built before this much space was required. Most dental clinics have what's called the open bay system, this concept. This is not conducive to IPC. So what kind of barriers can we use? What size should they be? What material should they be made out of? And are they permanent? We are asked to evaluate the ventilation in our dental clinics. But sometimes that may be difficult to assess, especially if we are in a professional building. I think we may need to ask a HVAC engineer to assist with determining the ventilation in our dental clinics. There are some other possible solutions, but again, this is a start. So if there are suggestions that can be made to make this easier, let us know. Dental offices do not have air negative rooms. So that leaves a question. Do you think COVID positive patients who have a dental emergency should be seen in a hospital setting? They do have air negative rooms. Now, in our dental clinics, we have several departments. We have administrative, reception, treatment, sterilization, laboratory, staff, and shared space in this professional building. Now, in the administration area, you may have a staff member in a back office who is sitting at a computer processing insurance claims, insurance treatment plans, insurance payments. This person may not be in direct contact with patients, so maybe they need a surgical mask, and that's enough. Now, in the reception area, of course, the person at the front desk is talking to every patient that day. And in the reception area, like the waiting room, that's all been changed. Magazines are gone, plants are gone, courtesy coffee, brochures, sometimes even pictures on the wall are gone. And the waiting room is actually not being encouraged to be used. In the treatment rooms, this is where most of the aerosol is, and anything that's in the aerosol, particulates, bacteria, viruses are in the aerosol. And so those treatment rooms definitely need to be looked at. We have sterilization areas, which often are small or are on the interior of the dental clinic. Same with the laboratory. Is that sterilization room going to allow 6 feet between each assistant? Then we have our staff areas. I know in my office, my staff area, my lunchroom was not very big. So to social distance at lunch with a staff of 8 to 10 people, how do you do that? And again, we have the shared space in our professional buildings where we have the public coming and going in the hallways, sharing bathrooms and sharing other areas in the public building. There are clinic scheduling changes. There will be fewer procedures done per day because the Organization for Safety, Asepsis, and Prevention on page 14 recommends about 15 minutes between each patient for sanitation. And again, Dr. Shelton Miller will let you know if that isn't a reasonable amount of time to turn that room over for the next patient to be safe for the next patient. So we are encouraging longer appointments to accomplish much more dentistry in one appointment. That will lessen the number of return visits to the dental clinic to complete a treatment plan. And dental outreach has been eliminated, such as going to nursing homes, which I did when I had a private practice. I would go to a nursing home and adjust a denture or polish a denture. But in this COVID pandemic area, I would never do that. We're not able to go into schools or Head Start programs or do any outreach like that. In our offices and in our clinics, the patient flow has changed because we don't want to have areas of gatherings, which we used to have quite commonly, especially at the front desk. Now with patient arrival, with the COVID protocols, we are asking patients to wait in their car to get text to come into the office. Well, I know with my own family, and they're really smart, but my mom does not have a phone that texts. She has a flip phone from probably 20 years ago. And my aunts, they don't text. So we have to think about that when and they still drive themselves to appointments. So we do have to think about things like that. Before our patients come into the clinic, we're doing temperature checks, we're doing questionnaires and asking them to wear masks and so on. And this is going to take one of our staff people away from the chair side or out of our office anyway. And this staff person will probably be doing this all day. And I described the waiting room modifications, and only patients are recommended to come into our clinics. And I'm just wondering, how will the American Indians and Alaska Natives cooperate? Longer appointments are recommended, but there are some patients that have a hard time with long appointments, such as the very elderly or maybe the very young. So if you have a wiggly 6-year-old that has ADHD, maybe you can only do 2 sealants in one sitting. So they would come back for 2 appointments because that patient is not able to sit there for a longer time. And we are modifying our dental procedures. For example, most hygienists now are not doing ultrasonic scaling. They are doing hand scaling. And for some periodontal patients, it is more advantageous to have ultrasonic scaling. The endodontists I know, they are not using ultrasonic instrumentation. They are using hand files. Also, patient checkout has been modified somewhat. Some of the offices I've talked to have the chairside dental assistant use that computer in the operatory to make the next appointment. So the patient just leaves the operatory and goes to his or her car. There are some unresolved workplace policy issues. Again, Dr. Shelton Miller will be talking in great detail about the day-to-day challenges in managing our clinics during this unprecedented time. One of the questions is, may the staff leave during working hours after being admitted to the workplace, for example, for lunch? Some clinicians do not allow their staff to leave, and other clinicians want their staff to leave and even suggest that their staff eat their lunch in their car by themselves, or even go for a walk to get fresh air. Well, I will tell you that in northern Michigan in January, when it's 8 degrees below zero and it's a blizzard, I don't think very many staff people want to go sit in their car and eat. The opposite problem might occur in Arizona in July when it's 100 and, I don't know, how hot does it get there? 110 degrees. I don't think you want to have your staff sitting in the car for lunch for that. So those are questions that need to be resolved at each clinic. And of course, PPE includes uniforms, clinic coats, face masks, face shields, hair nets, beard guards, shoes, and so on. And is this all supplied by the dental clinic? And who is going to launder the staff apparel? Can they take their own apparel home and launder it? Is it laundered on site? Or is it sent to an outside laundry service? And who will be checking on this laundry service to make sure they're using the correct antiseptic laundry soaps to sanitize the uniforms? And how can we reassure our patients that we are using IPC standards and that we are following all the protocols to the best of our ability? Now, let's suppose in your clinic, somebody turns out they did have COVID when you were treating them. And who's going to do that contact tracing? In our area in northern Michigan, we are mandated to report that to our county health department, and our county health department does that contact tracing. The separate medical or dental offices don't contact trace. And also there are social changes going on that I find difficult. We can't have staff parties. We can't go out to staff lunches. We can't go to staff picnics together. And the staff rooms are pretty small, so social distancing there at lunchtime is hard. Do we stagger our lunch hours? So all those things have to be answered. Now, a part of that is that our patients can't see our face when we're talking to them, and sometimes they can't hear us. I know my own relatives who are somewhat ages, they have trouble hearing. And when either a doctor or a dentist is talking to them with the goggles, face mask, and shield on, they don't hear it. They don't understand it. So how are we going to overcome that? And a final question is, can we mandate our staff to get the COVID-19 vaccine in order to keep their jobs? These are difficult questions, and there is new technology being introduced. My only purpose here is to make you aware of what's out there. I am not endorsed by any commercial entity, and I haven't used any of these products. I'm just letting you know that the dental industry is looking at these problems. They are looking at the problem of increasing ventilation, disinfecting the air, providing for our personal protection needs, over the patient suction units, handpiece modifications, laboratory and sterilization products, and other products such as a fogging machine that fogs clinics at night with antiseptic solutions. This is what's called the Vitashield air purification system. It's an ultraviolet germicidal irradiation and ventilation system, and it can be put in an existing clinic. It can be used in occupied rooms. It's mounted overhead. Its fans draw in 50 cubic feet per minute of contaminated aerosols, and ultraviolet irradiation disinfects the air, and this clean air is then recirculated into the room. This is another idea is what's called the Noveris Defend 1050. And this uses nanostrike technology combined with a triple stage can fill filter system for air cleaning. I just downloaded that from the manufacturer's website, but it does remove particles and aerosols from the treatment room. It's a freestanding unit and it can be wheeled about very easily. And you can plug it into any outlet. So there's no special wiring involved. Now, when it comes to personal protective equipment, this on your upper left, protect and sanitize station encourages healthy habits amongst patient and staff because they can easily access the sturdily mounted hand sanitizer, and there's tissues and face masks. It's very convenient. On the lower right is the Cpac RH-N95 mask sterilizer. In the beginning of the COVID pandemic, personal protective equipment was in short supply, and some of the offices had this unit, and so they were able to continue operating with their N95 masks because this is a fast, effective sterilizing method to sterilize the N95 respirators, and it doesn't compromise the respirator performance. This unit sterilizes up to 100 respirators per hour used in some hospitals. There is another option that's formed by the Battelle Sterilizing Company. The Battelle Sterilizing Company has special containers that you send your N95 respirators to them. They sterilize them and then they send them back to you. This is a photo of the ADS EOS Extraoral Dental Suction System. It's a multi-filtration unit that removes 99% of airborne particulates and pathogens, and that decreases the potential spread of infections and diseases. This arm is placed such that the suction unit is about 3 feet over the patient's head. It does so that it doesn't interfere with the operatory light or any of the other things. There have been handpiece modifications. This is a photo of the Metadenta air-free 90 Titan high-speed handpiece. And how this works is the air from the head of the handpiece is removed back to the dental unit's suction connection. And that minimizes aerosolization formation. And there are also new prophy heads that lessen splatter, and new prophy paste also is being developed that will lessen splatter. So perhaps a hygienist will be able to polish and will not have to have a high-speed, high vac suction by an assistant. In our sterilization areas, they're often small and often don't have an outside window. And there are, of course, many steps that's complex to ensure sterility of our instruments. So we have to think of how to disinfect this air and provide adequate ventilation and have enough room for social distancing. Perhaps a staff person works in here all day or works in the dental laboratory all day, doesn't really see patients face to face, but if they're working on appliances that patients have in their mouth or adjustments or polishing, they still are exposed to the pathogens that the patient brings to our office. So in review, new technology is being developed every day. There are new inventions every day. And we all need to make ourselves aware of these. And this is just a few examples. There's many more. This is courtesy of the Henry Schein Company. And it is likely that clinic modifications will continue to be recommended even when we're all vaccinated and even when this COVID pandemic gets over, which I hope is soon. Of course, the real issue is, where do the funds come from to meet all these challenges? It's going to be quite expensive. The NIHB and the CDC and OSHA and the ADA and you and I, we are going to work together to develop capacity building. We are individuals and organizations to work to improve and retain the skills, knowledge, tools, equipment, and other resources needed to practice dentistry competently and safety for our patients, for ourselves, for our staff, and for our community. And so I thank you for the grant funding for Project Firstline CDC. And thank you to the NIB for facilitating this webinar. And I thank the audience for your attention and your commitment to continuous improvement. At the end of the seminar, Courtney will give us our questions and Dr. Shelton Miller and I will try to answer them. Your continued support means everything to me. Stay strong.
Hey, thank you, Dr. Rickert. That was some wonderful information. And for the audience, as Dr. Rickert mentioned, we will, and I see there are some questions in the chat and in the Q&A. We are going to save those to the end, and I will address the questions that came through during Dr. Rickert's presentation. I will address them at the end. And now we'd like to welcome Dr. LaTanya Shelton Miller. Dr. Miller is the dental director for the Absentee Shawnee Tribal Health System at Little Axe Health Center located in Norman, Oklahoma. Dr. Shelton Miller completed her undergraduate degree in biological sciences with a minor in chemistry at Southern University in Baton Rouge, Louisiana. She went on to earn her DDS degree at the University of Oklahoma College of Dentistry. Upon graduation, she completed a general practice residency at St. Anthony Hospital in Oklahoma City, where she received a hospital certification in general dentistry and IV sedation. Prior to joining the Absentee Shawnee Tribal Health System, Dr. Shelton Miller owned a group dental practice, family dentistry, children and adults, with 2 partners in Oklahoma City, and had the opportunity to work as an adjunct professor in the Department of Community Dentistry at the University of Oklahoma College of Dentistry. She is honored to lead a team of 20+ oral health crusaders focused on improving oral health in tribal communities, the state of Oklahoma and the nation. Welcome, Dr. Shelton Miller.
Thank you, Carmen, for that introduction. And it's a pleasure to be here with you all today. It's been a journey since COVID-19 has happened in the pandemic. So I'm glad to be here and hopefully be able to share a little bit about what my clinic has done and maybe where we're going with all of this. So I'm going to try to share my screen here, hopefully. Can you see my screen?
Yes, we can.
Okay. So today, I would just like to briefly give you a little review of basic infection control practices that most of you probably are already familiar with, and then discuss some examples of how those same controls is related to the dental practice. And lastly, briefly tell you a little bit about what our clinic did to reopen our dental clinic to see patients beyond emergency care. I will say that, you know, I'm kind of in the trenches, so I'm no infection control specialist. I'm learning and kind of growing with everyone with all of this. So hopefully this is just, you know, some basic information and kind of what we have done that you might be able to take some pearls away and maybe utilize in your clinic as well. So let's see if I can figure out how to run all of this. And so, Carmen, I may have to have you control for me. Okay, so basically today I have about 5 topics I'd like to discuss, and I would like to first do a review of some basic infection control practices, such as standard precautions in infection control. as well as the hierarchies of control in the workplace and how some of those hierarchy of controls relate to, the dental practice, and a little reopening of our dental clinic. And lastly, some aerosol mitigation techniques and methods, and maybe some of the most effective ways that we know as of now to mitigate aerosol and microorganisms at the source. Next slide. And so standard precautions, what are they? Standard precautions are basically our work practices that are necessary to achieve the basic level of infection control. So in other words, they are our primary way to prevent transmission of infectious diseases and agents. And they must be used with all patients regardless of their infectious status. I will say in standard precautions includes contact with all, bodily fluids, not just blood. I have all bodily fluids underlined here because in the world of dentistry, really used to the term universal precautions, which refers to the concept that all blood and blood fluids are treated as infectious. Just like as in, COVID-19, the difference here is you never know if someone's asymptomatic or if they're unaware that they're affected. So the CDC some time ago kind of changed the concept of universal precautions and expanded it to include the term standard precautions. And so that's why I included standard precautions in my presentation today, because I really feel like in the light of what we've seen with COVID-19, it's definitely a much more comprehensive term. And I just wanted to go over the elements of a standard precaution. And basically it's things we all somewhat know to do, basic hand hygiene, washing your hands. In the medical field, and we say use your PPE, your personal protective equipment. Are you using your gloves, your mask, your eyewear? Respiratory hygiene, cough etiquette. Do you, cover your mouth when you cough? Are you coughing into your elbow, instead of just coughing out into the air? Using sharps safely. Are you putting sharps properly in the containers that they should go into? Are you using those nice red biohazard sharps containers? Also safe practice in injection practices. I have an example here of the re-scooping method. When in dentistry, we don't have the self-sheathing or self-retracting needles. So we do have to actually recap our needles, but a good way to do that is the scooping method so that you're not actually picking up the top and trying to put it on and have the potential to have an exposure there. Also sterilizing instruments and devices, and cleaning and disinfecting environmental surfaces. I'll have a little slide at the end of my presentation that kind of gives a breakdown of ways to disinfect your environmental surfaces. And next slide.
Hey,
And this,
Dr. Shelton Miller, sorry
yes.
to interrupt. Would you like me to share my screen for the slides? And
Yes, that might be easier.
okay, I can do that.
And then I can just have you progress for me. Thank you.
Yes, ma'am.
Okay, on this slide here, I have listed the hierarchies of controls. The inverted pyramid here depicts the controls that we use to manage. Let's see if she can get me back there. Okay. So the inverted pyramid here basically shows us how we can control and manage exposures to occupational hazards in our workplace and protect our employees. As you can see, as you progress down the pyramid, it gets a little less effective. And so the thought process here is that if you follow this hierarchy of control, normally it will lead to safer systems in the workplace, safer equipment use, and hopefully prevent, any risk of illness, and significantly reduce it at least. And so at the top of this pyramid, you see elimination and substitution. And that is basically where you're going to physically remove the hazard or replace the hazard. And in the middle, you have the engineering controls, which is where we're going to try to isolate our people from the hazard. And along the bottom, you have what is considered some of the least effective methods, but I'll say a little bit more about that in a minute, which is the administrative controls, which is changing the way we work. And then PPE, of course, protecting our workers with personal protective equipment. So now I want to discuss these controls a little bit more in depth. So next slide. And hopefully I can give you some tangible examples of each one of these that you can use in the dental practice. And hopefully you can quickly adapt some of these to your own clinic and maybe be able to take them back immediately. So for elimination and substitution, they're considered levels 1 and 2. They basically are considered the highest levels of in the hierarchy and are the most effective strategies to reduce hazards in the workplace. However, this is typically due because it doesn't require any behavioral changes from individuals. So while that's a great thing, they're also considered some of the most difficult to achieve just because, for example, COVID, can we just decide, oh, we want to remove it? No, it's there. So we have to kind of look at how do we look at completely removing it, or if we decide to do substitution, which is basically replacing the risk with either something that's less likely to occur, or if it does occur, it will be less severe and damaging. Although elimination and substitution, again, is the most effective way, it's kind of the most difficult to implement overall, but it's still something to strive for. So some of the examples of elimination and substitution in the dental practice, I just have a few listed here. There are quite a few, but these are some of the ones I think that just kind of jump out at me and I wanted to share. So setting up a screening process to check both employees and patients before they arrive to the clinic. For example, calling and confirming a patient's health before their appointment. We also have our employees, we have them before they enter the building to do a temperature check. We also ask our employees, if you're not feeling well, to not come into work. We can't stress that enough. You know, people really want to be here and help and take care of our patients. But if we're sick, we can't do our jobs effectively. And if we're sick, we don't want to make our patients sick. Another way is to look at going over the COVID-19 questionnaires prior to treating patients. And the reason why this is good for our clinic, we found, is that we have a lot of patients that travel from surrounding states. And so with us, the question was, well, there was some question there, should we see patients that are traveling from out of state? If so, should we do it if it's an emergency, if it's routine care? If we do see them, should we have them quarantined for X amount of days? And if so, should we have them test before their appointment? So for us, you know, going over these questionnaires was really important, and it still is. We decided ultimately to not necessarily have the patient quarantined, but we did decide to have a test before their appointment. And And if at all possible, try to have them quarantined for as long as possible, especially if it was an emergency. We don't want our patient to have to sit there for 14 days and they're in pain or have swelling. Some other alternatives and elimination practices, I think my screen is gone here, is basically using teledentistry as an alternative to in-office care. Teledentistry is getting a lot of press now. I'm personally love kind of seeing my patients in office, but teledentistry definitely has its place, and it's definitely something we have used in our practice to help triage our patients, to kind of have them screened before they come in and maybe take care of their issue without them having to physically come into the clinic. Another kind of substitution method we have here is silver diamine fluoride, and using it on carious lesions instead of utilizing dental handpieces. I'll be honest, before the pandemic, I didn't use SDF in my dental clinic, and now it's pretty much a staple. It's basically a chemical material that we can place on a carious lesion that either halts or really slows the progression of decay. So it can allow us to buy time until things are a little bit better with the pandemic. And it allows us to not necessarily have to use our handpiece and generate an aerosol. So not necessarily advocating for it, but it is something that it's something to consider. Also, hand scaling. Dr. Rickert kind of talked about, hygienists not being able to use their ultrasonic scalers. So one of the processes is, of course, to use hand scaling. Unfortunately, in a lot of our populations, you really do need to use an ultrasonic scaler. And so with that, it becomes a little bit more difficult to be able to truly treat your patients the way you would like to. Next slide. And so this leaves us to level 3 engineering controls. So engineering controls are basically processes and designs within our dental clinic that we install to kind of add some additional safety features and kind of help keep our employees kind of shielded from any type of risk. Engineering controls are considered the, least, a little less effective than the levels 1 and 2 in the workplace. However, depending on how you use those engineering controls, and I'll talk about that a little bit later, it can remove the hazard at the source and reduce it significantly. So how employees are shielded with these engineering controls are basically through a barrier type situation. And so some examples of engineering control in the dental practice, and Dr. Rickert discussed this too, was placing plexiglass barriers at places like the check-in and check-out areas and providing keyboard covers. We also like to look at social distancing patients in clinical areas and using every other operatory or closed bays if you have it as a good engineering control. One of the best engineering controls I think we have, and luckily I think every dental clinic should have it, is the high volume evacuation to reduce splatter, sprays, and aerosols. I'll talk about that a little bit later as maybe being one of our most effective ways we can prevent aerosols and kind of have some infection control. Also, utilizing instrument cassettes and plastic containers to hold dental instruments and prevent injuries when transporting. I know with COVID-19, we've discussed a lot about aerosols, but we're still having to deal with the same old things we've always dealt with in dentistry, any types of infectious diseases that might be on, and we don't know. COVID-19 could stay on an instrument for so many, we don't know that. And so just being able to have something as a barrier to help you transport is a good thing. I also have down here pre-procedural rinses to reduce microorganisms. Again, there's not a lot of research that truly says that it's going to control aerosol, but there is some evidence that it does help reduce microorganisms at the source. Next slide. So our last two controls is administrative and PPE. These two controls really limit or protect against any type of exposure or hazard in the workplace. And while it doesn't completely eliminate a hazard like maybe levels 1 and 2, I do feel like they are still really significant. Most of these are changes with the way people work. So it's often something that will be changed by management or the chain of command and implemented to reduce the likelihood that just about everyone in the workplace will benefit from. So administrative controls and PPE controls are considered the controls of last resort. Well, I have that kind of crossed out. I would perhaps like to say least resort or even essential. And why do I say that? Because to me, if I'm thinking of PPE in dentistry, I think PPE is quite essential, and I thought that way before the pandemic. So I don't see it as a last resort. I see it as something that at least at very minimum we do need it. Some other examples, of administrative and PPE controls in the dental practice are restricting the number of personnel entering the dental treatment area. Dr. Rickert also talked about, some of the social things that you do in a dental practice. And unfortunately, that means maybe we don't gather the way we used to. In my own clinic, we love birthdays. We love having potlucks. Well, we had a situation where, we're all gathering together. We're trying to social distance, but 2 days later, we find out one of our staff has been potentially exposed to COVID. Now, what do we do? So we had to make some decisions on saying, well, again, maybe you go to your car and you eat lunch, and not actually allowing everyone to come into the break room at one time. We also kind of look at the administrative and PPE controls, adjusting our appointment schedules. We can't see the number of patients that we once did. We had to reduce that because we're using either every other operatory, especially if you have an open system and not a closed-based system. We've had to make sure that there are hand hygiene stations. We always had them, but there's much more available now. We also, as an administrative and PPE control, increased the frequency of room and equipment cleaning and disinfecting. We're also wearing utility gloves during instrument processing. These are things that we did have in place before, but we're really making sure we're following the protocols that we've had in place. And of course, last but not least, using PPE, our personal protective equipment correctly, using our gloves, our N95s. Are our N95s actually fitting to our faces? And are we getting a good seal? Some of the issues that we had beginning is that not everyone could wear the same N95 mask. And so that was really interesting to try to navigate through. So next slide. So this slide here, as I transition to some of the infection controls steps that we did in our dental clinic to reopen, I put this slide here. I think everyone has probably seen this slide from the CDC. And I put it here because for our clinic, we chose to go with the slide on the left, which is your preferred PPE. And we decided to do that for aerosol generating procedures as well as non-aerosol generating procedures. On top of that, we're using our N95s, we're using our gloves, our face shields, and we're also using our surgical gowns that we dispose of. We don't actually use a laundry service. We actually use disposables. So we use a new gown for every patient. We also decided for our clinic to make mandatory to wear hair coverings. We just felt like if you're doing an aerosol generating procedure, that aerosol can land on you. So that's not necessarily something that you see here, but that is something that we have chosen for our clinic. And we have made shoe covers optional for the employees that want it. I will say that it does take extra time to put on this PPE, and it can get quite warm, as Dr. Rickert alluded to earlier, wearing all of this extra PPE. So I will say when we first had our first, face shield, I feel like we literally looked like we were going to walk on the moon. And I think our patients were thinking, well, my God, how serious is this? And so we still look like we're going to walk onto the moon, but it's a necessary procedures that we have to do. And we have chosen to do the CDC's recommendation for donning and doffing. And you can find that on their website under the dental guidance for guidance for dental settings. And we also reviewed donning and doffing with our staff, and we designated those areas where you can don and doff within our clinic. Next slide. So this slide has a lot of information here, but and anyone who's heard me speak before on the pandemic or COVID-19, you've probably seen this slide or a version of it. And I really like going over this slide because I think it was probably one of the more essential things we utilize in our clinic to get ourselves going and reopening beyond emergency care. So for us, we assembled a COVID-19 reopening infection control team. And that team consisted mainly of dental staff, 3 to 4 people. And I would say, of course, you're going to want to include, if you have an infection control kind of specialist that's within your whole health center, of course, you want them involved and you do want your administration involved. For us, we had to assign an infection control coordinator. Well, technically we already had one, which was our lead hygienist, and she is excellent. I would say if you're going to have an infection control, coordinator, they really need to be well organized. They need to stay up on the latest guidelines and recommendations for dentistry. And as alluded before in our previous presentation, this may require some more training. This might require some certification. And I do suggest if you're going to train your staff, if you can't find readily available videos, make your own. One of the other things we did, we determined any new infection control or workflow practices that we needed. We reviewed our current standard operating procedures and updated them as we needed to. We also, again, I allude to training. I really want to stress training for your staff. We, in dentistry, it's become second nature, but you want to make sure that you're really covering all of your bases. And I suggest competency training. We also determine our PPE needs and ability. There was a point in time where PPE was limited, and it still is quite limited, but we're making do. One of the things they're really pressing now and that we did early on is to make sure that you have access to every manufacturer's instruction for use for all equipment and instruments, and making sure that you're following it properly. We also instituted some safety measures for our patients and staff, and some of that I've kind of alluded to by putting in, some barriers and things like that. We developed a patient triage and scheduling workflow, and we broke it into stages when we reopened. And so the patient triaging and scheduling workflow changed according to those stages. And lastly, we did completed a risk assessment for our dental clinic, which I'd highly suggest if you haven't done it. It's basically to just see how has COVID-19 affected your staff, your patient services, and your surrounding communities, and are you at a higher risk? Thankfully, we have a lot of the vaccinations going on, so hopefully that risk of transmission is starting to subside a little bit. And what's your PPE burn rate and equipment needs? Next slide. So some of the other things we did telephonic screening of all our patients prior to the appointment, and we still do that. We did utilize teledentistry for a short period of time, and it was mainly as a triaging tool. We did a soft opening, which I highly suggest again, to limit the number of scheduled patients that you have and to stagger the appointments. Because when we decided to put together our infection control plan and our workflows, it looked really good on paper, but when you put it into action and you had your staff to work through it, and I highly suggest have your staff highly involved, you found that maybe things didn't flow quite as well. So by doing a soft opening, it allows you time to make any adjustments. We also decided to have early morning appointments for patients with increased risk of illness. Our thought process there is that as in the morning, there's less people that have entered the facility. So maybe there's reduced risk of any exposure to any infectious agents or potential hazards. And lastly, we considered 2 columns scheduling, columns for aerosol generating procedures and columns for non-aerosol generating procedures. And we decided to make those aerosol generating procedures closer to lunchtime. Next slide. And so we have here the infection prevention and control measures in the clinical area. And I'm just going to basically read these really quickly. We decided to make sure we were flushing our dental unit lines and air waters lines at the start of the day and between patients and after lunch. We utilized our closed surgical bays. We're lucky that we actually have 4 surgical bays for our extractions and our aerosol generating procedures. We also social distance our patients in our clinical area using every other operatory if we didn't use our surgical bays. We utilized a runner or a rover dental assistant when available, because once we were donned with our PPE, we didn't want to leave the treatment area. So by utilizing a runner, if we needed something, that kept us from actually leaving out of the area. We actually put together a patient entry and exit to control the clinical area and how patients are coming in and out. And like I mentioned before, we designated donning and doffing areas, and we designated no PPE zones. We were in as people had been a little lax. If you had your lab coat on, maybe you went to your office. Well, that was no longer an option. We also looked at making sure we were cleaning and disinfecting the rooms and equipment according to the CDC guidelines for infection control in the dental healthcare setting. And we are only using the EPA approved disinfectants and utilizing the manufacturer's instructions for use. And on the CDC's website, you can find a lot of the approved disinfectants. For a moment in time, the ones we typically would use were in such high demand, we had to look for alternatives because the ones we typically use just weren't available. So if you're still having that issue, please go to the CDC website and kind of see what other alternatives you have. Next slide. Next slide. So one more back. Carmen, if you could go one back there, the opposite direction. The opposite direction. One more. There we go. And so I have listed some aerosol mitigation methods. By no means are these the actual ones that I would say you need to do, but they are good ones to go by. Using pre-procedure mouth rinses like chlorhexidine or 1% hydrogen peroxide mixture, using a HVE or HV isolation system like a dry shield or IsoDry, using an extraoral suction. Dr. Ricketts mentioned the ADS system, which is what we purchased in our clinic. I'm not advocating for it, but it has been very helpful. Using a portable genocidal UV air purifier, ultraviolet cabinets or wands, a microcab to reduce some of the airborne particles when adjusting dentures and partials, and of course, flushing and maintaining your dental water lines. And as of late, there's been an article on reducing the speed of your dental handpiece that it just cuts down on the amount of aerosol and spray that you're having. Next slide. And this next slide is just some pictures and some of what some of these equipments look like: the microcab, the extraoral dental suction, and the air purifiers and the cabinets. Next slide. So lastly, there's been a lot of talk lately about mitigating aerosol and microorganisms at the source. So some of the best ways we can do this is using a pre-procedure rinse. However, again, it's not necessarily going to cut down on aerosol, but it is known to help at least reduce microorganisms in the mouth. Using a HVE to allow providers to capture more of the particles at the source, and using HVE isolation systems in conjunction with your high volume evacuator. I will say for us, I feel like we do all three of these together along with our extraoral suction unit. And I feel like we're doing a really good job at mitigating aerosols and reducing our microorganisms within our clinic. Next slide. And this is just the equipment maintenance reopening checklist for you to have if you haven't already reopened your clinic, or if you have not really utilized all of your equipment and your operatories. It's just a good equipment checklist to have to make sure that everything is functioning properly when you do open. Next slide. And this is just a operatory prep list. This was what I was talking about earlier about the environmental surfaces. Kind of gives you a breakdown of what you should do to kind of help making sure that you're controlling your environmental surfaces within your dental clinic. And next slide. And I always like to end my presentation with giving any type of helpful infection and prevention resources. This list here is, you know, it has, if you can go to any one of these websites, you can find a wealth of information. I will point out the second one, the CDC training, basic expectations for safe care. I like that particular website on the CDC because it has modules that your staff can watch and train and make sure that they're up to date on their basic safe practices. And I apologize for my little diagram there being so small, but hopefully you can see those nice little guideline booklets there. And next slide. And those are some references there. And next slide. And I apologize, my computer just went to sleep on me. And so I just like to say thank you for, you know, being a part of this presentation today. We're all kind of navigating these waters together, and if I see that there's probably some questions there. I have my information here. If you have any questions for me after this presentation, please feel free to reach out to me. Again, I think we're in an unprecedented times and we're kind of all navigating this together. And I really appreciate the Project Frontline for having these types of presentations and really trying to get in the forefront of all of this. So thank you.
Thank you, Dr. Shelton Miller. That was for sharing all of your wonderful information. So we are a little bit over time, but we did want to make sure that we are able to answer some of the questions that came up. And let's see here. So the first question we had was for Dr. Rickert. And the question is, as far as PPE is concerned, when loops are being worn, does dental staff have to wear a face shield? Some have found it difficult to wear both.
The practitioners that I've talked to, and I did wear loops when I was in practice, but I did not wear a face shield. It wasn't required. I wore a mask, obviously. So, especially for the endodont, well, any practitioner that thinks they need them, but in order to see the field and do a competent job, you have to visualize what's going on intraorally. And that's what the loops and that's what the light helps us do. So they are very important to do competent dentistry. Some of my friends that are still practicing, my endodontist friend, she's just using the loops because she feels she has to have them to do the endodontic procedure, and she hasn't found a solution to that question yet. Another friend of mine, he has found a shield. I'll have to ask him about it. A shield that goes more forward than the shield that you see generally used. So it's 3 inches in front of the face, I think, and that does not touch his loops. So that is a really good question. And there is, the people I've talked to, just in a general sense, have not come up with an answer for that. Do you have anything about that, Dr. Shelton Miller?
Well, at the beginning, we did have quite a few, just about every provider wears loops. What we found is, I would say, majority was able to find some type of shield that would cover their loops and still be able to see properly and still be able to utilize their light. We have maybe 1 or 2 that literally, because of the way the loops are made, they just can't wear a shield, so they are using the side shields on their loops and just using the loops by themselves.
Right.
So it's been a kind of a trial and error
Right.
of find something that would fit for each type of loop.
Sorry, we don't have a really good answer on that.
Right.
That's day-to-day dentistry, I'll tell you.
Okay, thank you. And I also want to mention we are going to be putting a poll in the Q&A shortly, so everybody watch out for that and hopefully answer the poll. Our next question is from Alfreda, and this one is also for Dr. Rickert. Can you provide where the 15-minute between each patient is found? I looked at dental settings under the CDC COVID area.
Again, it's I'm looking for it right now. Okay. When you are, and maybe Dr.
And you
Shelton Miller can address this too. It just takes a long time to turn the operatory over. It's not a 2-minute thing. Okay, the 15 minutes is on page 14. The instructions were formulated by the Organization for Safety, Asepsis, and Prevention on page 14. OSAP.
OSAP.
Oh,
Yep, acronym OSAP on page 14.
And I will be honest, you know, depending on what type of procedure you're doing, maybe you need more than 15 minutes.
I think so.
So I would just piggyback on that. I think it's going to be somewhat of a individual preference within your clinics, but a minimum of at least 15 minutes.
Okay, thank you. And there's a question from Martha. She says Q-Air carries an all-in-one unit that has an EOS system and HEPA air filter system available. That works great. So I guess a comment, but not a question.
Well,
And the next question is also from Martha. It says open bay clinics. What are the recommendations for those regarding airflow and aerosols containment?
Well, I guess I can take this here. I do know that they're really recommending, I don't know that every clinic will be able to do it, is basically have an HVAC specialist come out to see what your airflow is and kind of see how your clinic is made up. If that is not something that you can readily do, I would suggest, and you have the space, to use every other operatory if at all possible. And if that's the case, it's going to take a little bit longer time, maybe 30 minutes in between each patient, to kind of help mitigate some of that aerosol and let things settle. Up to an hour maybe. So, and Dr. Rickert may have some other thoughts on that.
Well, I know the open bay concept is really utilized a lot in orthodontic offices. So they might have a little bit different needs than we do, because they don't use high speeds in very many of their procedures, just once or twice, I guess. So again, there are engineers, HVAC engineers, that know how to achieve 50 cubic feet per minute exchange of air. I don't really know how to achieve that, but they can guide us. And when you talk to the dental manufacturers that Dr. Shelton Miller and I showed you pictures of, I'm not endorsing that. I'm just, I mean, I am endorsing 50 cubic feet per minute, but the equipment that has been developed, I'm not necessarily endorsing that. I'm just saying it is out there. And if you have open bay, you probably will need some of those over the patient devices and some of those other devices if you have open bay.
Okay, great, thank you. And also for Alfreda, what if you have negative pressure rooms?
Negative pressure rooms are, from what I understand, and I think Dr. Shelton Miller will agree, those are the safest way to provide dental treatment. They are extremely expensive. I don't know if a dental office would have one. They require a separate room that's sealed, and it has its own ventilation system, and its air is exited out the building, I believe. And when you open the door to go in there, you only open the door to enter. And when you open the door, there is air that is being blown into the room, so that air doesn't come out into the rest of the dental clinic. So if you have that in your dental office, then that's a good thing. Do you have that, Dr. Shelton?
No, we do not have it in our actual dental clinic. We do have a negative pressure room in our health center. And so that has something that we have discussed. Do we want to have one specifically for dental? So we do have the ability, if we just had an emergency patient and they were, confirmed COVID-19 patient, that we could potentially at least examine them. We wouldn't necessarily have the equipment to actually do the work there with us, but at least we could examine them to find out what their needs are. So I don't know that dental offices can really, from a financial standpoint, have negative pressure rooms.
That's what, maybe if you're building a new office from the ground up, you might consider that, but that is a question because we will have COVID patients that are active with the disease,
Mhm.
14-day quarantine period, and they'll have a dental emergency with swelling or, it needs to be taken care of. So, and we want to do that, but we want to do it safely.
Okay, and a follow-up question from Alfreda. Let me bring that up really quick. Asking, do you still have to wait 15 minutes when in a negative pressure room?
I don't believe so.
I do not have the answer to that. My own personal opinion would be yes. But that is not, I don't have any, tables or laboratory equipment to test that out. But I think you would have to wait that long. Yes,
And I honestly don't know the answer either.
I don't know.
Okay, let's see if any other questions are coming in. Does anybody else have any other questions to type in the chat? Or in the Q&A? Okay, we have one more in the Q&A. If fogging rooms, do you still wait the 15 minutes?
I would say yes.
I would say yes.
And we actually fog before patients in the morning, at lunch, and in the evenings. But we don't do it in between each patient, however, though. I would say even if you did, I would still wait the 15 minutes.
Okay, thank you. And we also saw that somebody had their hand raised. Did you have any questions to add? Please type it into the chat or in the Q&A. Okay, I'm not seeing any other questions come up. So thank you so much, Dr. Rickert and Dr. Shelton Miller. Thank you for sharing all your wonderful information. And thank you everybody who has attended. We hope that it's been helpful for you as well. And we are wrapping up here. And for everybody here, we'll watch out for a post-webinar survey. We'd like to hear your feedback, and it's excellent information for us in planning future webinars. And also we have another webinar for Project Firstline that we will be hosting next week. So please be on the lookout for that information as well. And with that, thank you so much.